If your ambulatory practice runs on Greenway Intergy, you already know the billing side of the platform is incredibly robust. Between the claim scrubbing logic and clearinghouse integrations and real-time eligibility tracking, the entire revenue cycle framework is built right in. But the software doesn't actually process the claims. People do. And without a highly specialized operator driving those tools, the whole system stalls. Knowing how to execute generic medical billing does not mean knowing how to navigate Greenway Intergy. A biller has to understand the specific payer edits, clearinghouse configurations, and denial queues native to this particular environment. Because Greenway is a fully integrated platform, charge capture happens directly inside the clinical note. If the template is slightly misconfigured, or if an operator doesn't know exactly where to look for charge exceptions, revenue leaks quietly out of the practice. Practice managers often end up frustrated with the software, but the platform is doing exactly what it was designed to do. The issue is a severe gap in specialized institutional knowledge. Tracking MGMA's report, we see wage inflation over the last decade. Wages for medical administrative staff climb sharply, jumping between 39% and 52%. This heavily impacts roles practices rely on to get paid, namely general accounting and managed care staff. At the same time, remote-friendly health systems and payers are actively recruiting experienced billers away from smaller independent practices who simply cannot match those higher wages. This horizontal timeline illustrates hiring a replacement. Notice this distinct warning zone, the 60 to 90-day ramp-up penalty required for a new hire to become independent. During these 90 days, claim volume drops, denials pile up, and senior staff lose critical hours to training. Trying to maintain an in-house EMR billing team means accepting that inevitable staff churn will create costly 90-day productivity black holes on a regular basis. This bar chart compares historical initial claim denial rates using Kodiak Solutions data. Look at the 2024 column, which spikes prominently to 11.81%. Within that data, medical necessity denials increased 5%, and request for information denials rose 5.4%. MGMA's 2024 benchmarking report confirms this pressure is widespread, showing more than half of U.S. healthcare organizations now face denial rates exceeding 10%. When we apply HFMA data to a stylized financial ledger for an average $3 million practice, the damage is clear. The math isolates a massive $144,000 loss sitting entirely in unresolved claims. Days in AR start creeping upward. Once that metric crosses 55 days, it signals a systemic failure. By the time a claim hits 120 days, the probability of ever collecting that money plummets below 50%. In a climate where every 10th claim is kicked back and requires manual rework, a brief staffing delay quickly spirals into an operational crisis. The standard reaction to this crisis is hiring a generic business process outsourcing firm, or BPO, but that creates the shared staff problem. Outsourced workers typically log into their own external systems, completely separated from your actual Greenway EMR. This disconnect forces manual data reentry. It creates reporting mismatches and leaves severe accountability gaps. When rework data lives in a system you can't see, no one knows who actually owns the denial. The external billing system and your internal practice management operate entirely out of sync, grinding against each other instead of driving the process forward. Because they are working outside the EMR, those external teams lack visibility into the clinical side templates where your Greenway charge exceptions frequently hide. Generic outsourcing forces you to sacrifice visibility and control, creating a massive reporting mess without actually solving the root EMR compatibility problem. There is a third alternative to both internal HR struggles and generic BPOs, the dedicated specialist model, designed by companies like Staffingly. The baseline requirement for this model is that every assigned specialist holds active AAPC or AHEMA credentials before their very first day. This animated quadrant chart maps out the options by cost and competency. Generalist hires sit high cost, low competency. Generic BPOs sit low cost, low competency, while Staffingly specialists occupy the ideal quadrant, low cost and high competency. Because these EMR native specialists work securely inside your Greenway Intergy environment, The 90-day learning curve is completely eliminated, reducing the go-live timeline to just 14 days. Accessing your system directly requires strict compliance infrastructure, which is why the model maintains SOC 2 Type 2 audits, ISO 27001, and HIT trust frameworks. The human specialist doesn't work alone. They utilize AI-augmented tools for smart claim routing and predictive workload management to handle volume efficiently. Incoming claims and audits are instantly and flawlessly sorted to the exact right specialist, which prioritizes high-value tasks automatically. Pairing direct EMR access with AI-assisted auditing means your team stops putting out manual fires and shifts their focus to maintaining an error rate below 1%. The median base salary for a medical record specialist looks manageable on paper, but the true loaded cost of an in-house billing FTE actually runs between $55,000 and $75,000. This comparative bar chart breaks down the exact financial difference. The $55,000 minimum in-house loaded cost sits on the left, compared to Staffingly's fixed $20,748 annual cost on the right. A bracket highlights the gap of over $34,000. Extrapolated for 2 billing positions, both bars double in width, and the savings bracket recalculates to show a massive $68,000 annual capital savings. The model is designed to hit core operational benchmarks within 60 days, specifically driving your days in AR back down to a healthy 30 to 45-day window. If you make a bad in-house hire, the damage is permanent. This model replaces that risk with structural flexibility, operating month to month after a 14-day risk-free pilot. It comes down to a clear trade-off. You sacrifice a physical person sitting in your office, and in exchange, you gain day one EMR competence, automated accuracy, and a